want you to close your eyes for a moment and imagine that you're being rushed to the hospital in an ambulance. You have excruciating chest pain and you can barely speak. When you get to the emergency room, a nurse comes in to see you. "What brings you in today?" she says. You start to tell her, but she interrupts you. "Have you had this happen to you before?" You're trying to collect your thoughts. "What were you doing when it started?" "Nothing unusual, just watching a movie on TV." She hooks you up to a cardiac monitor and draws some blood, and then the doctor comes in to see you. "Hello, how's your pain? Any history of drug use or drug abuse?" Then suddenly it dawns upon you. You're an African-American man from Baltimore. You're in your early 20s and you're slender. They've assumed that either you have sickle cell anemia and must be addicted to pain medications, or that you are an IV drug user and you're coming in with a cocaine-related heart problem. This is only one of many scenarios in which racial and ethnic minorities and people from other disenfranchised groups are on the receiving end of poor treatment when they go in for health care. It's a rather dramatic scenario, but unfortunately not an uncommon one. Inequities in healthcare are extensively documented in several countries across race, ethnicity, social class, and other characteristics like weight and physical disabilities. These inequities occur for all kinds of tests and medical procedures in all kinds of healthcare settings. They occur in rural and urban areas. They occur in developed and developing countries. And in the United States, they occur on the East Coast, in the West, the North, the South, and in the middle of the country. This problem has been going on for over 100 years. But now there's a whole new field of research called disparities research that has evolved to address this problem. I've devoted my 20-year career to the study and elimination of disparities in healthcare. My particular areas of focus are doctor-patient relationships and healthcare system engagement with their communities. Now let me tell you how I got here, why I'm so passionate about it, and why I think each and every one of us should care about it. First of all, you're probably wondering why I'm dressed like this. This is my native garb. I was born in Liberia, West Africa. It's a small country, and it was founded by free slaves and free blacks in the early 1800s who left America and went back to Africa in search of freedom and a better life. Some of my ancestors were freed slaves, and others belonged to a tribe called the Golas, who were rural farmers native to West Africa. My paternal great-grandfather was actually a chief in the Gola tribe. Growing up in Liberia, I was very much aware of how good my health and quality of life were. You see, my parents were professionals, and I went to an international school with children whose parents were professionals and diplomats. Other children I saw on the streets in Liberia were not so fortunate. Many of them had parents who had never been educated. They lived in small, crowded homes, often without running water or electricity. They went to schools that barely had chairs or desks, much less like the fancy equipment and books and the well-trained teachers I had at my school. It used to make me sad, and on some level, I knew it was unfair. Why did some people have so much and some so little? This sensitivity that I had and the sadness I felt about what I saw around me made me determine that I would do something to help to improve the lives of others. And it still defines me today. I mean, I can barely watch a documentary about poverty or hunger or something like that without getting really upset. But back to how I got here. My parents worked really hard, and they actually showed me a lot of what I know. My father was a surgeon, and my mother worked as a librarian. And together they established the Cooper Clinic. It was a small hospital that provided medical services to a broad cross-section of the community. They also worked as community activists. So they volunteered for things like improving adult literacy and eradicating leprosy. And from watching my parents, my brother, sister, and I gained an appreciation of the value of service to others. We also, from interacting with so many different culturally diverse people in our community, had a comfort level of interacting with people from different groups that I came to realize was somewhat unique. During this time, this is how I also developed my interest in becoming a doctor. Well, on my 17th birthday, my whole world came crashing down. The government of Liberia was overthrown in a bloody coup. Soldiers went from house to house, terrorizing people, especially people who belonged to what was considered the privileged class of Liberians, like me and my family. Several of my friends and relatives were victimized and killed. Many of the parents of my friends were shot and killed on the beach because they were involved in government, or simply because they were part of the middle or upper class. I remember thinking that we were all going to die. I was petrified. I was never going to grow up, never going to achieve my dream of becoming a doctor, and I would never get to come back and help to make the lives better for those kids who didn't have the good life I had. And for the first time in my life, I realized what it felt like to be part of a minority group and without power to protect myself. The other thing I realized was maybe my life wasn't that great after all. I mean, how great could it be if I could see all that poverty and hardship around me? Fortunately, my family and I survived that experience, and we came to the United States that same year to escape the violence there. After graduating from college and going to medical school, I did my residency at a large inner-city hospital right here in Baltimore. And I realized in seeing patients in Baltimore that some of the struggles they faced were not that different from the struggles faced by people back in Africa. My patients in Baltimore had financial struggles, exposure to violence, discrimination when trying to obtain work or housing, very similar to what I had seen growing up. And the hardest part of it all for me, the most painful part really, was watching the communication problems between these patients when they would come into the hospital and the doctors and nurses that were part of the system. There seemed to be such a gap between those patients and the doctors and nurses and the other health professionals in the system. It was not unlike the gap between the poor people in Liberia and me and my upper middle class family and our international friends. Well, one night I was on call and I was asked to come to see and admit a patient who I will always remember. She was an African-American woman who was close to my age. Now, all I knew before I came down to the emergency room to see her was that she was in her early 20s and had HIV/AIDS. Well, immediately, all kinds of thoughts ran through my mind. How did she end up like this? Was she someone who had been sexually promiscuous? Was she an IV drug user who had shared dirty needles? I mean, most of the patients in Baltimore who had HIV had not gotten it from blood transfusions. So, anyway, I don't know how many of you are familiar with the grueling hours of residency training, but I was pretty stressed out and tired that night. I had already admitted 8 or 9 patients, and I really wasn't in the mood to talk to another patient and get into another long, drawn-out conversation. I just wanted to get my work done and get to bed. But when I saw her, I was struck by how small and how frail and how afraid she looked. Seeing her actually made me think she could have been one of my friends. But for, fate of birth, she could have been one of my friends or one of my relatives. And I think she must have felt that same familiarity with me or connection with me because she opened up and told me about how her boyfriend, who she didn't realize had been using IV drugs, had given her HIV. And that I was actually the first doctor that she felt comfortable sharing that whole story with. And that was a real turning point for me. I realized that it was going to be more important for me to not just be a good doctor to individual patients, but to actually work on a broader level to try to bring about change for people who belong to these underserved and disenfranchised groups who were trying to get health care. So after my residency, I went on and got research training in public health. And my colleagues and I have done several studies. Some of the studies we've done have shown, for example, that African Americans have lower levels of trust in doctors than whites, and that ethnic minorities across the country actually report less respectful treatment from doctors and less encouragement to participate in decisions about their treatment. We then went on to record actual medical visits. We wanted to find out what was actually being talked about and how those visits actually went. And one of our studies showed that when African American patients see a white doctor, that those visits are actually shorter, and the doctor and the patient sound more rushed, less interested, and less friendly. I mean, imagine how those patients feel. Like, it's bad enough when that happens to you if you're in a store trying to buy something or if you're trying to order something at a restaurant. But when you're trying to get health care and you're sick, and you and your family members are looking for answers to really serious questions that could impact the rest of your life, still, we actually weren't that surprised, because don't most of us feel more comfortable interacting with people who are like us? Well, as a doctor, I felt that doctors couldn't possibly be doing this intentionally. I tried to put myself in their shoes, and I thought, well, maybe we should try to understand more about what's going on subconsciously in doctors' minds. What are their attitudes about patients who belong to these social groups? So we got together with a bunch of psychologists and sociologists, and we developed a study where we would measure the racial attitudes of doctors and see how that influenced the care they delivered to patients. We gave the doctors a test called the implicit association test. Have any of you here tried it? Just a few people. Well, it's available online, and it's a very interesting set of tests. So basically, the test asks you to group good and bad words with the faces of people who belong to different social groups, like race. And you're supposed to do the test as quickly as possible so that it doesn't indicate something that you've thought about a lot, but something that you would automatically do. For the race IAT, if you are doing a test and you're able to group good words and white faces and bad words and black faces faster than you can group good words with black faces and bad words with white faces, then the test shows that you have an implicit or subconscious bias favoring whites over blacks. Now, 70% of the hundreds of thousands of people who have done this test show a bias favoring whites over blacks. So doctors are no different. Our study was the first to show, though, that when doctors have this bias, that they actually communicate more poorly with their African American patients, and that those patients actually rate them as being less respectful. So you can imagine how well this goes over when I share these results with my physician colleagues. I think most of us don't really want to believe that we have race or social class or any other kind of bias for that matter. So, it just doesn't go over that well, especially doctors who are out there actually trying to help people. So part of the problem is actually getting people to accept that this is going on and that they might be contributing to the problem. But the other issue is, what do we do about it? I mean, you can just tell people this, but then what? So we don't have all the answers yet, but we're working on it. And I'll just tell you one example of something we've done that shows some promising results. So one study we did, we actually trained doctors. We gave them communication skills training so that they could develop stronger partnerships with patients from low-income and minority groups. And then we trained community health workers to act as coaches to minority patients and to patients from low-income areas to make them feel more empowered when they went in to see doctors so that they could ask questions and, state their opinions about things. And we actually showed some really good results with that. So I think there's hope. But these problems didn't develop overnight. I mean, it's not like doctors go into their field, or other health professionals for that matter, because they want to treat people from different groups differently. And it's not as if poor people or minority patients want to feel disempowered when they go in for health care. But these are things that we are programmed with and that we learn very early in our society. We get all kinds of messages about them. We just look around us and we see who are the influential people and powerful people. Who lives in the nicer houses and who drives the nicer cars and who looks the most fashionable, and we subconsciously begin to value those people more than other people. So it's really deeply ingrained in us, and it's learned early. And it's going to take a while to undo that. We're going to have to work on an individual level, but these problems also occur on organizational and community and societal levels and policy levels. We live in a really race and class conscious society. All of our systems, our political systems, our social systems, and our healthcare system are set up so people who belong to certain groups can get more advantages and opportunities than other people. So we're going to have to make changes on all those levels. Now, one really important policy change we've made recently, in case no one has heard about this, is healthcare reform. The Affordable Care Act will provide insurance coverage to people who have not had it and allow them to get basic health services, as well as keep them from going bankrupt if they get really seriously ill. This is a phenomenal step, I think, in the right direction on the journey to eliminate healthcare inequities. But we're still arguing about who should pay for it, right? Who should pay for this? Well, guess what? We are all already paying for it. Increasing rates of crime, unemployment, addictions, physical and mental illnesses are all a result of health and healthcare inequities. And in fact, the American population is less healthy than most developed countries because of this problem. Well, I don't want to leave here with you feeling really down. I know this is a very sobering topic. There is hope. I think each and every one of us here has a sphere of influence. Where are you on a daily basis where you can make a difference in this? If you're a patient, a family member, a community activist, you're a student, teacher, preacher, lawmaker, business person, or artist, or health professional, what can you do? The choice of one person can change the world. I'm one African woman whose ancestors were free slaves and rural farmers, and whose parents rose to middle-class status in a country where the majority of people still live in poverty. I've used the pain of watching my home country descend into civil war and witnessing discrimination around the world, as well as the blessings of strong family and of educational opportunities to try to help others see this problem of health inequities in a different light. For me, working to overcome health disparities has been a lifelong journey and a labor of love coming from a desire to uplift humanity. There's still so much more that we need to do, but I leave you with this one thought. Biases are learned, but they can be unlearned, and we can overcome them if we accept that they exist and change what we do to respond to them. I agreed to do this talk because I believe this is an idea worth spreading. Will you join me on the journey? Yeah.